Okay, so we're going to go through a few osteotomies and talk about various nitty-gritties of it. Most of this has already been discussed in detail, so we'll try and skip parts which are repetitions. So let's start with a fairly straightforward case. That's a typical patient profile that you'll see. A 54-year-old gentleman comes to your clinic with knee pain, inability to do activities of daily living, gets night pains on and off. He's a non-smoker, he's in good health, wants to stay active, has seen me for about 3 years now in the OPD. Every time I get a scanogram done, it's slightly worse. Now it's crossed the medial joint line, it's sitting in space now. So the options we are having is HTO, double level, uni or TKR. We are in an osteotomy session. So we are, I'm just clarifying. So because Roshan will just come and say do a TKR on him, so I'm just confirming.
I won't do TKR because I don't do TKR. So the panel is open. Yes, okay. Please go ahead.
Good. So the deformity analysis shows this. So when you do a bone ninja planning, there's a MLDF of 93 and MPT of 83. So let's start from the left hand side. Rick, you can start. So this is a typical 54-year-old gentleman with a double level deformity. How will you tackle this?
Okay, so if we look at this, there is a soft tissue component. I mean, his joint length and congruence angle is open, but he's got his LDFAs in Valgus, and he's also got contributions from his big contribution from his tibia. So at 54, I think that he is on. We're an osteotomy discussion. I think at 54, this is someone you got to talk about being realistic about this. This might be a total joint, but since this is an osteotomy session, this would be a double level.
Let's make it simple. He doesn't want any replacement.
Okay, well, this is the double level. This is a double level osteotomy.
Okay.
And especially when his mechanical axis is outside his knee.
I think the biggest failure here was the failure of the surgeon who waited 3 years to indicate him. I would have indicated him 3 years ago, and it would have been a single level, and his medial joint would have been better.
Well, it's very difficult to convince patients in India. He just came every year to show me and said, no, not for surgery yet, I'm still okay. So.
No, I understand that, but I'm making a joke. But my point is, we have to recognize that early intervention will save knees and will prevent larger surgery, and prevent more complicated surgery.
True. Raghu,
yes, sir. So we with previous.
So we're doing a double level osteotomy for him, as we know. I was going to subtract 1 millimeter from the correction ratio because my MPT was already 93 to compensate for JLCA. What's your approach? Would you subtract anything for soft tissue laxity or just leave it like that?
I would like to leave it like that.
Leave it like that? Yeah. Mukesh, would you subtract anything from your correction to compensate for soft tissue laxity?
So with this, as I told you, simulation, it depends on, I may go 1 degree more on the femoral correction and then I not do, but if it's isolated HTO, I would definitely subtract that laxity.
Okay, so I decided to reduce 1 millimeter, so the excess JLCA minus 2 upon 2 comes to about, so if you think of your JLCA as highest level as 4, so it will come at 1 to 1.5, so I reduce 1 millimeter from the correction. That's the intraoperative standard imaging that you see. So did a lateral closing wedge on the femur, medial opening wedge on the tibia, use the same graph from the femur onto the tibia, and you got a really good straight knee. This is 3 years down the line, 1.5 years down the line. He's still doing remarkably well. The alignment is good and he's quite a happy patient. So just a quick take home is correct planning is key to success. Never shy away from an osteotomy as and when you need it.
Bhushan, going back to the previous X-ray, do you still recommend the lateral DFO on Varus correction, or nowadays you started shifted to medial DFO?
There is another case that will come to that.
Okay.
So I'm going to discuss this in details later. So has anyone has a strong viewpoint on medial DFO versus lateral DFO in the panel? Would anyone do something differently than this?
No, so the conventional would be medial open wedge and for the DFO closed wedge. Yeah, that's what generally we follow.
Only thing, I would still prefer to go up to Fujisawa in such patients because they are grade 4 complete arthritis.
Okay.
Yeah, this case is actually quite difficult in the sense that this is the one where you do the femur first, and then you titrate the tibia.
Exactly.
Because this is the one you do want to overcorrect, but if you overcorrected him too much, he could swing way into valgus. So this is one where you do the femur, close it down, and then you plan for a 5, 6, 7, you build your tibia up.
So I always stop at the lateral tibial spine, as you see in the last image, because there is still some opening on the lateral side, and as he starts weight bearing, the hypomocylin is going to shift. So I think it will come and settle nicely between 55 and 60 for grade 4 arthritis in the medial compartment. That was my thinking, and that the patient seems to be happy, so that's a good thing. So from Varus, let's go to Valgus. Similar profile, 56-year-old female, mild, so the pain is pretty mild. She's not in agony. So the lateral compartment, as we know, is very forgiving. The pain doesn't hit them till the time is grade 4 and very severe. Her main issue is a patellofemoral pain. Again, she's also not keen on TKR, and she's fairly active. She's been referred by a colleague from Kolkata to do an osteotomy. So my hands are tied. I'm going to do an osteotomy for her because she's come specifically for osteotomy. I did have a chat with her. She doesn't want a TKR, had a bad experience in the family. Her sister died because of something post TKR. I warned her that that even might still happen with osteotomy also, but she's keen on doing something about it. The MRI shows grade 4 arthritis in the lateral compartment. Of course, we can think of lateral uni, but her weight bearing axis is falling way outside. It's 125% in terms of the tibial plateau. So it's a very severe deformity. As you can see, her MPTA doesn't seem that bad. Her LDFA is affected. So the deformity seems to be more in femur. I'm going to just pass through this because the point I'm making is a bit different. So the planning shows that it's going to be an 11 millimeter closing wedge. I agree the software planning I've done opening, but it becomes very easy to do that on software, to do opening osteotomy and just replicate that with a closing wedge on the other side. So that's 11 millimeter of closing wedge. That's a big correction. So anything else anyone will do apart from a medial closing wedge DFO for such a patient? Parag?
Interesting case. First of all, I would like to do always a scopy before starting this, because sometimes, as Mukesh said nicely in his talk, that sometimes there may be a lateral meniscal problem, there may be a ACL mucoid, so you take care of that. In this case, since it's a valgus knee, there may be some apparent lengthening for the patient as well. So if I do a open wedge, then I'm probably going to lengthen her more. So I would rather prefer a closed wedge osteotomy in this case to correct the valgus. That would be my thinking.
11 millimeter, is it slightly more than what you would accept?
11 is okay.
Okay, Sunny?
Yeah, I would keep it not completely overcorrected.
Yeah.
Keep it in slight valgus.
That's an excellent point. Roshan, where will you stop when you're correcting a valgus?
I think for me 11 mm is little more for DFO. Usually you should not correct more than 7 or 8 millimeter, because otherwise there will be internal impingement of the ACL. That's one. Secondly, if possible, I don't know what is the MPTA here. MPTA
89.
is normal 89. So if possible, the MPTA I will try to correct a little bit more.
So you will think of a double level?
Double level osteotomy, and I'm very sure that hips are normal.
Hips are normal, everything else is normal.
Absolutely normal. Okay. So there is no rotational problems in the hips.
No. So decided to go for a 11 millimeter closing wedge on the medial side. Got a perfect isosceles triangle, so there won't be any step off. I was very happy with myself at this juncture. Took out the bone, put a hinge pin, and was very happy thinking what can possibly go wrong. And then my registrar does this. He tried to help me and just broke the hinge completely. Despite having a hinge pin, the hinge breaks like that.
That's because it's 11 mm.
So it's a big correction, I'm not denying that. But my registrar tried to correct it by moving the foot rather than letting me do it. It's fine. We have all done this when we're training. So
It's always the registrar's fault.
So you can always blame the registrar. That's absolutely true. Now the situation is, this is 7 o'clock in the evening. I'm in a big hospital, but I don't have a plating system ready for a lateral plating. I do not have staples. So how can you fix hinge now? So start again with Roshan. We'll go in the opposite direction now.
I'll call my phone a friend. This is the implant guy.
Okay.
Nowadays we have a rapido implant guy, so they can immediately come for your rescue. Some of the implant companies, they have autoclaved implant sets also in Mumbai. So it's not, I'm not joking, this is a reality. Some of the implant companies, they have pre-autoclaved implant sets also. So please keep this number handy when you're operating a smaller setup. In bigger setups, like where I work, usually we have many surgeries going on. So you can pick up something from somewhere and put it.
Okay, Sunny?
So that's not be a problem.
The trauma surgeon is just next door, so I'll just ask for help.
But to answer your question, since the specific question you answer, you don't have a plate, you don't have a staple. So I think you probably have a plate for that side. So make sure it's a robust plate, whatever you're going to fix it with, and then open up laterally and put a couple of screws under vision. You know, so that way you can tide over the situation. Since you don't have staples and plate, if you had them, then it's a different way of fixing it.
Mukesh?
Reduce it well.
Okay.
See that you got your correction. Put 2 KYs, one anterior and posterior. By the time you
I gave it to
fix
Raghu.
the
You know the answer. Raghu.
Yeah, same thing, sir. Robust fixation on the medial side and probably anterior and posterior screws on
So
the
we are
lateral
going
side.
to use an angle stable fixation. We are using a pretty strong plate on the medial side. Anil, anything different you would do? You will put a plate?
Your title is wrong. It says how to fix the hinge now. There is no hinge.
Okay.
Go back to your x-ray.
Can you
how
go back
to-
to X-ray?
Right,
Book
right.
back.
So
Yes,
how is-
This is not a hinge fracture.
This is complete fracture.
This is subluxation. No. It's a big difference. When we talk about, whenever you deal with a hinge, opening or closing, when you have subluxation, you need maximum fixation.
Okay.
This is like doing a derotational femoral osteotomy. It's a completely unstable osteotomy.
Yeah, I agree.
And so it's not a hinge anymore. It's a complete fracture.
Rick?
I think that, in these cases, you should always have, and in this case, it didn't sound like you had it available, but you should always have dual plates available. This case, at this point, this is a highly unstable, this needs to be double plated. You can't fix this adequately
Okay.
without double plating.
Okay, so this,
You don't need another Tomofix here. What you just need, a pelvic recon plate. Just put a plate.
Sachin, you have a comment?
oh God.
So I think, before we look at this fracture and look at these complications, I think what has happened here is that if this was my case, I would have failed before the surgery, because when you do any surgery, you need to have backup plan A, B, and C. So I would not undertake any surgical procedures, whatever time of the day or night it be, unless and until I anticipate all the problems and have a backup option. So I think that's the first thing to all the people there. Don't just go blindly into a case with 1 plate and 4 screws. You need to have everything that you will anticipate like this, and you should have that kit ready. Do you agree or you disagree, all of you?
No, that is always the ideal
That
case
was the
scenario.
message
but
I was going to give. You
Sachin-
stole my thunder again, so it's fine. Okay, so I'm human, I learn from my mistakes. So
But see, what happens is, practically speaking, all of us may not be able to do that, because to have that kind of armamentarium, to have that kind of, backup and extra plates and screws, sometimes it's difficult. So I think we should know how to tide over and how to
that's
circumvent.
what I'm showing. So you put the hinge screw on the other side to protect it. You can stack them. So you can put 2 or 3 hinge screws anterior to posterior to correct to hold the osteotomy, and watch them very carefully for next 6 weeks. Don't allow them to weight bear. And shit happens, but as Sachin was saying, you need to be prepared for hinge break in every osteotomy. So this happened, I think, a few months or years back, and since then there is always a plate on standby every time I do it. This is 6 months post-op X-ray, and osteotomy surprisingly healed well. She's very happy. Just spoke to her yesterday actually when I was preparing this talk, and going back to complete normal function.
Can you go back to your original osteotomy? So my one pearl here would be, is that you want to have the inferior guide wire just above the posterior femoral condyle. This inferior guide wire is a little too proximal, and it's more likely to get a hinge fracture. If you start that first hinge wire a little bit lower, it's hard, at least on that view, maybe that's the superior one, I don't know.
So I always try to get isosceles triangle. So
Right.
when
You want to be
closes-
right above the posterior femoral condyle shadow.
Okay.
And there is no hinge left, almost you are reached up to the lateral cortex.
So my saw is supposed to stop there. So between the 2 pins, it's supposed to stop about 5 millimeters from the end, but it didn't. Okay. So this happens. It's okay. So that was a quick advice. So be prepared for hinge fracture every time. But you have the option of stacking screws on the lateral side if you are struggling, if you don't have anything else, and you can still get out of a mess or a major puddle such as this. So let's change gears now. This is a 14.5 years of age. The reason I'm saying 14.5 is because she's a very young girl, but she has severe valgus on the right side, as you can see, of course. Her main issue is inertial pain and pain with activities of daily living. She's unable to run and is getting depressed now because everyone in the school is able to do a lot of activities. And for some reason, someone had told her to wait till skeletal maturity. So that's how she is presented to me with a leg. Sorry, I'm showing that we are going to operate because she's on table, but you can see the level of deformity, pretty severe deformity she has, non-correctable. The patellar tracking is bad, but there's no subluxation and there's no dislocation of patella yet. So that means its MPFL is still intact. Let's go to the planning and then we'll discuss. The deformity is bi bone, so what's the biosteal? I don't know what the word is. So there is disturbance on the tibial side as well as femoral side. Question to all the panel, would you do a double osteotomy at 14? Start from Mukesh.
This is the higher limit of MPTA if one want to accept. So I may just go up with doing distal femur osteotomy.
Okay. Raghu?
Yes, sir, I would agree with that. I do a femoral osteotomy and probably see in future, maybe consider as a second stage if necessary.
Anil, any different?
Well, I just broke a femur a minute ago, so I don't want to do that big of a correction again and break another femur. So I'm going to do a double level. A double level osteotomy at 14 doesn't, that question doesn't make sense to me.
I agree, but
Younger the patient,
but you heard
can handle more surgery.
Yeah, I agree.
And a bone loves two smaller corrections. Muscles love two smaller corrections than one big correction.
Again,
Muscle
that was
and
going to be
bone.
my take-home point. You already answered the question. Okay, Rick, anything?
So full disclosure, I'm very big, have a very big patellofemoral practice. And so I would be thinking double level osteotomy, but I would also really want to know what the rotational profile in this patient is and I also would think that their pain is not just lateral joint line pain. This patient has maltracking and that's probably more.
I don't have a CT rotational profile, but I completely agree with you. So the planning shows that we are going to need a correction both on the femoral side and the tibial side. Again, on planning I do open wedge, but it's always a closed wedge, so it looks a bit odd on the tibial side, but I'm going to do a closing wedge tibia and a closing wedge a femur as well. So again, any different thinking from Roshan, Sunny?
No, I agree with the plan. Double level osteotomy, distal, lateral. I would do a distal femur open wedge, lateral side, and medial close wedge.
Okay. Parag, anything different?
Yeah, so I will, as Rick did mention, I'll study the patellofemoral joint more in detail because with such amount of valgus in 14, and you did show that there was a little bit of subluxation. So I would, go through all the Q angle, which is obviously increased, which is one of the precursor for, dislocation of the patella. I would measure the trochlear inclination. I would measure the patellar inclination and also see the consistency of the MPFL. And if I need to add something, I wouldn't hesitate to add at this point of time if my MRI does show me some different values.
Okay, so as thought, I went for a distal femoral osteotomy, medial closing wedge, fixed it nicely. And even after doing a good 7 millimeter closing wedge on the femoral side, the Mikulicz point is still at about 90%. So I think HTO is a medial closing wedge HTO is required in her because this, again, learning from my own mistakes, I will not do an 11 millimeter correction in her. So 7 millimeter was good enough in my book. So I did a closing wedge proximal tibial osteotomy, fixed it with a nice plate and got the correction to again about 55%. I do not, since this is not an arthritic case, I have matched the alignment of the opposite limb. The opposite limb is about 55 to 60%, so I've just matched the same thing. So that's the end result. I haven't put a hinge screw on the closing wedge because it was pretty stable, and that's her about 7 months from surgery. She's able to walk comfortably, the osteotomy has healed well, and she just messaged me yesterday that she took part in a running competition. She came 4th in the running competition in the school at the age of 14 and a half, so 15 now. So this is indeed a gratifying surgery. So message here is, I think no shortcuts. A double level osteotomy is done when it's done. When it's required, you have to do it. You cannot say someone is 14 and I'll just manage with a femoral osteotomy alone.
So pre-op, the MLDFA was 77.
I must have mistaken it, yeah.
We did only 7-degree closure.
Yeah.
So,
So it got to 85, 84, 85. Again, I have burnt my fingers, so I don't want to overcorrect it. So if you want, I can show you a post-op scanogram to see this
That
come
was
back
just to
neutral.
misguide you, Mukesh, and you fell in a trap.
Now, one of the key points that I mentioned in the last patient was someone told her to wait for skeletal maturity. How many of the panelists will wait for skeletal maturity in these patients, or would do something else? So similar patient group?
5 cc is already fused in this patient.
No. So,
No?
No. So I've got an MRI to confirm as well. This is just an example. This is not osteotomy thing. So as luck would have it, this is something I did yesterday. So valgus deformity on right side. On the scanogram it does look, but on Tanner grading on the MRI everything looks open. So again deformity is on both sides, and this is what I did yesterday, what I just did a growth modulation. So if you don't do it, send it to someone who does it, but don't ask the patients to wait for skeletal maturity. Does everyone agree, or does anyone have a different point of view?
Totally agree, because this is such an easy surgery, and doing an osteotomy after skeletal maturity, you do this surgery, it corrects very well. In fact, sometimes we have seen patients in our own hospital when they don't come for a follow-up and they actually overcorrect. So that's the problem with this. So this is a wonderful surgery. This should be done as and when it is detected. Get an elbow X-ray to just see that the growth is not complete, and then go ahead and do this surgery. It's a wonderful surgery, very rewarding.
Anil and Rick, anything you want to add? Do you guys do this or send it to your pediatric guys? Or?
Yeah, I mean, I do this with my pediatric guys, and I do this a lot with ACLs. So that's something else to do. The one thing you haven't done a lot in your deformity analysis, which I think you should, if you're not doing bilateral surgery, is also measure height.
Yeah.
And that's part of your algorithm of opening versus closing. It's just another variable if you're doing a lot of advanced osteotomies.
I agree.
I have one point to make. Problem here is when they manifest at 10, 11 years of age, that is an ideal age to do this temporary epiphysiodesis. But when they are at 13, where the secondary sexual characters have already started to come up, then you can't predict the deformity correction that can happen.
Fortunately, she's not skeletally fully mature yet.
So I think you can ask the audience also the question, at this age, would you leave it till it matures skeletally, or would you still do this?
So you need to look at the Tanner grades, secondary sexual characters, pubic hair, axillary hair, all of that has been checked, and it's confirmed that there is still growth left. She's about 7 inches shorter than her mom and her elder sibling. So there is a chance of growth. And are we burning any bridges by doing this? That's my main question. So audience, will everyone think about this, or will they wait for a couple of years and do a double level osteotomy in her? Raise of hands who will go for this, and I think majority people do agree with this. Okay, one last case, I won't bore you too much. Another varus knee. Now this is an interesting one. This is a 31-year-old really active guy, complains of pain and deformity in his left knee, limps while walking. There is shortening on the left side, and to make it slightly more interesting, he's had a fracture when he was 14 in the femur, which was operated, complicated by infection, and required some 3 or 4 surgeries to get back to normal. That's him walking. So you can see the left limb has multiple marks from the sinuses or external fixator marks, whatever it is, and he's got varus and thinning of the whole lower limb and shortening. That's his scanogram. So there's an old healed infection. His CRP is completely normal now. There are evidence of healed sinus tracts or pin tracts. He doesn't remember. He was very young, 17 years back. He doesn't remember. But funny enough, there is tibial lengthening and femoral shortening. So the body has tried to compensate by increasing the tibial length, but the femur is looking really weird. It's a bit deformed and not looking very good, but there is femoral varus. That's the planning. So there is limb length discrepancy of 2 centimeters on the left side. Right is longer, of course. It's all in the femur. Actually, it's 3 centimeters in the femur. The tibia is longer by 1 centimeter. MPT is around 90 and LDFA is around 96. So there is femoral deformity causing this. So that's the deformity analysis. So how will you manage this? Let's start with Raghu. Raghu, how will you manage this? Anything specific you want to avoid, do, use a fixator or something different?
Yeah, I don't have much experience in such cases, but yeah, if I would get this case, probably I'll refer to my colleague who does Elizoro. Probably that would be the best thing because to manage both the shortening and the angle correction. Yeah.
Okay. Anil, anything different?
Yeah,
Would you treat him like a normal patient?
I have no interest in this.
Oh, God. Rick, you're not interested or you are?
I often do these with my partner who's a traumatologist, and I think he would do a lengthening with over a nail on the femur, and then
He's 31. He's not bothered that much about shortening. His main issue is varus and pain on the medial side of the knee.
So that is more important. He is not bothered about his shortening. See, 2 centimeter shortening can be easily compensated. No one operates for 2 centimeters. He has come here for knee pain. Knee pain with femoral varus and tibia.
Okay, Roshan, what will you do?
See, this is a tricky situation. Anything you do, there are very high chances of infection. That is one. And I have seen lengthening over the nail. That works wonderful. You can correct deformity and you can lengthen. But obviously, you have to be an expert surgeon in that fraternity, which I am not. So,
Sunny, anything different?
Fixator associated correction would be good for this. So you can address both the
But there
shortening
is,
as
the
well as-
CRP is normal. There is no infection for last 16 years.
Still with multiple surgeries in the past for infection.
you just cannot take it for granted.
Yeah,
That
okay,
is
it can
Parag.
add up.
So irrespective whether the patient had an infection or not, the ideal answer would be, of course, an external fixator assisted correction, hexapod or Elizara, whatever you are comfortable with, correct the height as well as correct the deformity. But in my hands, I am not an expert. I don't do it. For me, it will be a medial open wedge osteotomy to correct the varus. I will fix it so the medial side, when I open, I get length, and I would do that.
So that's the planning. Normally we go for a closing wedge osteotomy on the femur as a rule. So if I need to correct the deformity, I'll need a 9 millimeter closing wedge osteotomy, but that will make him shorter by another centimeter. So now 2 centimeters going to 3 centimeters. I'm getting a full correction. So can I think of a medial opening wedge here? So when I do a medial opening wedge of 9 millimeters, my limb length discrepancy goes down to just a centimeter. So that seems to be the right answer. Of course, the main worry is about infection. So CRP and everything has been done. It's showing no signs of infection as such. So Mukesh, do you agree with this plan or do something different?
No, I'll go with medial DFO.
So that's what was done. If you look at the femur, it looks really odd. It doesn't look like a normal femur. There is a significant change in the anatomy here. So medial opening wedge distal femoral osteotomy was done. The biplane was a bit too thick in my opinion, but that's fine. But you could get a good fixation and stability in this patient. And that's his post-op X-ray. Everything healed well by God's grace and there was no infection in him. And I think he's coming next month for implant removal at about 3.5 years from the surgery.
That's scanogram. You have any?
I don't have scanogram, sorry. So that's him walking. That's yesterday's image. You can see he's put on some muscle on the left side now. He says that he doesn't need a shoe raise on the left side now, and he's got full range of motion. He's able to sit cross-legged. Of course, we are not talking sports in him, but he's able to go back to most of his normal activities as such. So take home. Opening wedge works in femur equally well as tibia as long as you don't break the hinge, or if you protect the hinge or save the hinge or fix the hinge, you're going to get a predictable good result. I've bone grafted him because the bone quality was really inferior in him, but he's done remarkably well. So I think that completes our case discussion. Any comments or questions, please go ahead.
The first comment is no one should challenge success. You have been a very successful surgeon. Thank you.
So I have one point to make. Initially in my practice, I would have done probably a lateral side correction, a closing wedge. But the fear in my mind at that point of time was the femoral artery. But let me tell you what my father always taught me: be close to the bone. So subperiosteally dissect everything. The femoral artery is far away. You're not going to even see it, and you can actually go all the way up and get a good plate to fix it medially. Don't worry about the vascular structures. You're far away from them, as long as you're just close to the bone.
Yeah. Any other comments, any questions or any comments from the audience?
No. They're all stunned.
Good. That was
Are they? Yeah? You are stunned or you are?
So,
Yes.
just one question.
Somebody is not stunned, yes.
Just one question.
Yeah.
The case that you discussed of a young female and we did a double level osteotomy, do you think there is any role of particularly a V-shaped osteotomy, the anterior V-shaped osteotomy for correction of that valgus and the femur?
If there is significant deformity, you can do a dome, a reverse dome, a V-shaped osteotomy as described by Ponky Firer from South Africa.
And that will take care by the just a single osteotomy.
Yeah,
you don't
so-
have to do a double level osteotomy.
But then you are leaving a deformity on the tibial side, compensating it on the femoral side. So you are over-correcting on the femur, not correcting on the tibia. So if it was a case where there is a deformity only in the femur, not in the tibia, that would have been an option. A dome works really well. Or you can do a diamond osteotomy where you take a medial closing and lateral opening at the same time. So you can take out the wedge from the medial side, put it on the lateral side and fix it 2 plates. That also works quite well.
Okay. Thank you very much, gentlemen. That